So let's continue looking at the anatomy of the heart, going into the various tissues, and then looking at how the heart will function in terms of its kinematic responsibilities. So when we look at the heart, we look at it in terms of tissue layers, just like we look at with all other organs and structures of the body. The outermost tissue layer is what's referred to as the pericardium. The pericardium is made up of a fibrous band of connective tissue that limits the total amount of volume that the heart can take within the mediastinal cavity of the thoracic cavity. There are two parts to the pericardium. This is referred to as the fibrous pericardium, and there's what's referred to as the visceral pericardium. The visceral pericardium can also be referred to as the epicardium, which is going to be on the outermost edge of the heart structure itself and is going to overlie the coronary blood vessels that we looked at in terms of the external structures. This visceral parietal layer of the pericardium have what's referred to as seral epithelial cells that will be producing a mucus on them, so that what ends up happening is that the parietal layer of the pericardium will not bind onto the visceral layer of the pericardium. And then the fibrous layer of the pericardium is going to restrict the total amount of volume that the heart will be able to distend to. Deep to the epicardium, the visceral layer of the pericardium, we have the myocardium. The myocardium is predominantly made up of myocardial tissue, cardiac muscle, but we will also see the conductive pathway within that. Deep to the myocardium, we will see the endocardium. The endocardium is once again made up of a seral epithelial tissue, which will produce a mucus lining to it. So that what ends up happening is that the trabecular curvatures within the myocardium will not bind onto itself, so that what ends up happening is the heart will be able to distend upon fill and then collapse upon contraction. And so any of the organs that we see that have the ability to expand but not rupture will have these trabecular structures, these kind of little invaginational waves. It's these invaginational waves that allows us to have the trabeculum that we saw within the bone, because all it's showing is just showing this kind of this irregular patterning that we see on the internal structure of organs. So the myocardium itself is going to be predominantly made up of cardiac muscle, but we're also going to have modified tissue, which is referred to as the uh, conductive pathways. Most of the myocardium is, in terms of cardiac muscle, is going to be Y-shaped muscle that is going to be connected via intercalated discs. The intercalated discs are simply specialized gap junctions. That's going to be a combination of gap and desmotic junctions, so that what ends up happening is that when we have contraction excitation, the muscle actually undergoing its kinematic change. What ends up happening is that one muscle cell will cause the next muscle cell, and the next muscle cell will cause the next muscle cell to contract in a unison of cells. What ends up happening is the way in which the cells orient themselves is it sets up networks of cells that lie on top of each other at varying angles, so that when we have distension upon fill, we do not get any gaps to occur between the cells. There are two unique characteristics about cardiac muscle. Cardiac muscle is aerobic obligated tissue, which means it has to have a constant rate of perfusion, which is why we have to worry about needing bypassing of coronary vessels and why we have to worry about the LAD in particular. It will prefer lipid metabolites over glucose metabolites for regenerating ATP, because the rate at which it needs ATP is much less than what we saw with other excitable tissues. It is amitotic, which means that once the heart has reached its maximal size, it will no longer divide and form new myocardiums, new muscle cell itself, which can become problematic because the way in which we'll get a stronger muscle is either by allowing for greater distension of the ventricles and atria to utilize more elastin, elastic connective tissue, or we're going to have to get more actin and myosin there by allowing those cells to actually become larger, as opposed to what we saw with the skeletal muscle where we start getting new myonuclear domains. We don't get that same effect that we see within the cardiac muscle, and that's so that we can allow for the kinematics of the heart to function. So it will function as that four-chamber pump to move fluid through the body. So let's take a look at the underlying histology of the myocardium. So what you remember is that the myocardium is going to be this bifurcated, this kind of Y-shaped cell with the central nucleus that's going to be held in place by the intercalated discs. That's going to form a mesh-like structure within the heart that will orient itself so that we have opposing orientations between cardiac muscles. So what it does is it establishes uh, one cell that will be vertically with another cell that will be perpendicular to it, and then the next cell will be different in terms of each layer. So what's up happening is that the myocardium itself establishes this network that ensures that there's going to be no gap in between the cell layers, so that as the heart expands upon fill, we're not going to have any leaching of blood into the interstitial regions around the cells. Now, as we work inwards into the cells, what we'll start noticing that there is a distinct type of junction that occurs within the intercalated discs, where we have this kind of combination of desmotic and gap junctions that occur. This cardiac muscle itself is going to be a centrally nucleated striated muscle. It has a whole bunch of mitochondria within the cell itself. The reason for the high amount of mitochondria is because the tissue is aerobic obligated tissue, which means that it's going to be utilizing aerobic metabolism, mitochondrial metabolism in particular, to regenerate ATP for the contraction cycle. In terms of fuel utilization and fuel obligation, it can use a variety of fuels. However, because of the rate of turnover that we see within ATP, it is actually preferential to lipids as opposed to other fuel sources that it can't have access to. So it'll prefer lipids or lipid metabolites. If we go further into the cardiac muscle, what we'll start noticing is that it has a very similar orientation that we saw in terms of cytoskeletal structure to the skeletal muscle itself. So we'll see transverse tubules, we'll see sarcoplasmic reticulum, but what we don't see is we don't see this entirety of the cell filled with the cytoskeletal proteins, the myosin, the actin, the titin, well, there's no dystrophin, but the titin, the M binding proteins, the myosin binding proteins, the titin linking the actin molecules together to the Z lines. Because of the centrally uh, populated nucleus, we don't see as much of the cell being filled with the cytoskeletal proteins, but there's a counterbalance to this. And because cardiac muscle is amitotic, it does not divide. The modification that we see within cardiac muscle in terms of growth happens to deal with the cross-sectional area of the cytoskeletal protein structures within the cell itself. So the cells actually get larger when the cell undergoes hypertrophication. So we were talking about left ventricular hypertrophy. What ends up happening is that the actual amount of myosin and actin within the bundles within each cell actually becomes more abundant for each of the cells, and the cells actually get larger as opposed to what we saw with skeletal muscle, where we start getting more myonuclear domains in terms of the hypertrophication that takes place. And this has to deal with the amount of space that's available for the heart to have within the mediastinal cavity of the thoracic cavity itself. So let's take a look at the actual kinematic functions of the heart in terms of what it does, because remember, it's a four-chamber pump. So what's up happening is that it's a two-stroke four-chamber pump. The two-stroke is atrial contraction, systole, followed by atrial relaxation, diastole, and then ventricle systole, contraction, followed by ventricular diastole relaxation. The way in which the heart functions, it is what's referred to as autoregulatory and autorhythmic. There are distinct cells within the conductive pathway that set the rate at which the contractions will take place. These autoregulating cells, these nodal cells, have specialized ion channels, which we refer to as funny channels. And the reason why we call them funny channels is because they don't have the same kinematics as other channels. And what it does is it allows for the nodal cells, the SA node and the AV node, to be able to never have a stable um, isoelectric resting member potential. Their resting member potential is constantly heading back towards zero. So it's going to undergo depolarization at irregular patterning. However, it's not really irregular. It's going to have a set pattern in which the whole entire heart will undergo its single contraction cycle every about second. Between about 900 milliseconds and 1200 milliseconds, we'll have a heart contraction. The regulations and responses that we see within the heart is all based off of what's referred to as the Frank-Starling law and principles. I've given you an article that details changes within there. I've given you supplemental reading materials in the special considerations that discuss this, and we'll talk a little bit more about these issues when we get to the physiology of the heart later on. So let's take a look at the conductive pathway. So the conductive pathway starts with specialized cells within areas of the heart known as the nodes. What ends up happening is that these nodes have a non-stable resting member potential that will allow for depolarization moments to start within the heart and pass through the heart through the conductive pathway without neural intervention. You cannot cognitively make your heart contract. Your heart will contract independent of neural stimulation. Now, we can modulate the rate at which the conductive pathway functions by changing autonomic tone, by increasing the vagus nerve input to increase acetylcholine, which slows down the rate of depolarization, or by having sympathetic tone, increasing the exposure of epinephrine and norepinephrine to increase the rate of depolarization based off of whether or not we're opening and closing ion channels. And once again, we'll get more into this when we talk about the physiology of the heart. So here's the conductive pathway of the heart. The conductive pathway of the heart starts at the SA node, which is going to be just inferior to the entry point of the vena cava. So you got to remember is that we have this kind of kink in the heart orientation. What's referred to as the SA node. The SA node will pass its depolarization wave through the atria, through what's referred to as the internodal pathways. There are three distinct pathways. There's the Wenck-Bach pathway, Bachmann's pathway, and Thorel pathways, which allow for depolarization to spread from the SA node through the atrial myocardium. The internodal branches will come down towards the ventricle from their lateral aspect and superior aspect off of the right and left atrias towards the inferior medial part of the ventricle, and they'll junction on the AV node. The AV node allows for a small bit of pause within the depolarization wave so that the atrias are able to contract independent of the contraction of the ventricles. We want to have contraction cycle of the atria independent of contraction cycle of the ventricle because we want to have this two-stroke pathway, because otherwise there's no mechanism for fluid to flow through the body. The AV nodes will then pass through what's referred to as the AV bundle. The AV bundle is also referred to as the bundle of His, H-I-S. The bundle of His will then branch apart into what's referred to as the AV bundle branches. As the AV bundle branches hit the apex of the heart, they will bifurcate and spread through the ventricle in what's referred to as the Purkinje fibers. The Purkinje fibers will then head and innervate the ventricle muscles. Now notice coming off of the bundle of His and coming off of the Purkinje fibers, there are secondary pathways that are heading out into the papillary muscles. These secondary pathway heading out to the papillary muscles are the moderator bands coming off of the bundle branches. This is going to ensure that the papillary muscles are able to contract prior to the full systole contraction of the ventricles so that the valves are able to close and ensure that fluid is moving in one direction only. So, how are we able to pass this depolarization moment through the cells to ensure that we have this contraction wave taking place within the heart? It's all about the intercalated discs. And what the intercalated discs are going to allow for within the conductive pathway is a means for ion movement to take place through the specialized gap junction. So we have to think about these gap junctions is like electrical synapses where we're simply allowing for the ions to flow from the SA node through the pathway. As it flows through the pathway, the excitation wave spreads to the surrounding tissues. And as it spreads to the surrounding tissues, those tissues can reach their threshold. And once they reach their threshold, they'll go ahead and go about doing their contraction. This whole passage is what gets picked up off of the ECG, the electrocardiogram. And we'll get much more into this when we talk about the physiology of the heart and the contractions of the heart. Now, one of the things that we can pick up in terms of this contraction kinematics is what's referred to as heart sounds. And heart sounds are the lub dubs that we normally think about when we think about the heart, in which we have two principal sounds. The two principal sounds are referred to as the S1, S2. S1 and S2 correspond to lub and dub that we hear when we auscultate, listen to the heart, where lub is the indication of ventricular contraction and the closure of the AV valves, the tricuspid and bicuspid valve, whereas the dub is the indication of ventricular diastole and the closure of the semilunar valves, the pulmonary and the aortic valves. Now, sometimes the valves don't always close correctly. When valves don't close correctly, what we'll hear this kind of disturbance in fluid flow. This disturbance in fluid flow gets picked up as what's referred to as a murmur. Murmurs can be picked up sporadically through most of the population. Just because we hear a murmur does not mean that there is a pathological condition. However, continual murmuring is an indication of stenosing of the valves. That's where the valves lose their flexibility and will not open and close correctly. If we continue hearing murmurs from individuals, then we have to start worrying about stenosing of the valves and a pathological condition within the heart. The other sounds we'll hear we refer to as S3 and S4 sounds. These are gallops. These are any irregular sounds that we hear within the normal periods between S1 and S2 or between S2 and S1. The gallop is an indication of hypertrophy of the ventricles in which we do not get full contraction and ejection of the blood. And so we end up having a double beat within the contraction wave. And it actually sounds like a horse galloping, which is why we call them gallops. Gallops are always pathological, whereas murmurs may or may not be pathological.
These include the aortic area, in the second intercostal space at the right sternal border, the pulmonic area, in the second intercostal space at the left sternal border, the second pulmonic area, in the third intercostal space at the left sternal border, the tricuspid area, in the fourth intercostal space at the left sternal border, and the mitral or apical area, in the fifth intercostal space at the left midclavicular line.
So let's go ahead and listen to S1 and S2 sounds as well as the sound of murmuring.